Hello, welcome to this month's GIE Author Interview Series. I am Dr. John Wong from Hong Kong. On behalf of the senior author, Professor Joseph Song, and the Asia Pacific Working Group on Colorectal Cancer, it is my pleasure to share with you our manuscript entitled Adenoma Detection Rates in Colonoscopies for Positive Fecal Immunochemical Tests versus Direct Screening Colonoscopies. This paper will be published in Gastrointestinal Endoscopy. As you know, there is increasing emphasis on performing high-quality colonoscopy. Currently, the adenoma detection rate is the key quality indicator in colonoscopy screening. And that is because a low ADR has been correlated to an increased risk of interval cancer. Professional societies have recommended ADR for men be benchmarked at 30%, while that for women be at least 20%. But what about fecal immunochemical tests, FIT-based screening programs, where colonoscopies are performed after positive FITs? These likely represent higher-risk individuals with increased prevalence of colorectal neoplasia. In 2018, the U.S. Multi-Society Task Force on Colorectal Cancer recommended a male-specific ADR target greater than 45% and female-specific ADR benchmark greater than 35% in FIT-positive colonoscopies. However, as graded by the task force, this recommendation is supported by low-quality evidence. So to justify this higher ADR target for FIT-positive colonoscopies, we performed a study to compare ADR, advanced adenoma detection rate, and adenoma per colonoscopy among average-risk subjects who underwent direct screening colonoscopy versus FIT-positive colonoscopy. Our study was an international multi-center cohort study of prospective CRC screening cohorts from 8 sites across the Asia-Pacific, including Hong Kong, Japan, Korea, Singapore, and Taiwan. Subjects had underwent one of 2 screening strategies, either direct screening colonoscopy or colonoscopy after a positive FIT. All sites used the same FIT brand, OC Sensa, with the same cutoff for positivity at 20 microgram hemoglobin per gram feces. We only included asymptomatic individuals over 50 years old with colonoscopies complete to the cecum and with at least fair bowel preparation. Patients were excluded if there were histories of inflammatory bowel disease, prior screening colonoscopy, colorectal neoplasia, colorectal surgery, or first-degree relatives with colorectal cancer. Our primary outcome was ADR. Male and female-specific ADRs were also determined because the U.S. Multi-Society Task Force also provided sex-specific ADR recommendations. Other outcomes were advanced adenoma detection rate and adenoma per colonoscopy. So from the 8 sites, almost 5,400 individuals met the inclusion criteria of having a complete screening colonoscopy with at least fair bowel preparation. 2,900 subjects had direct screening colonoscopy, while the remaining 2,500 had underwent FIT-positive colonoscopy. In FIT-positive colonoscopy, the overall ADR was 53.6%, with a male-specific ADR at 61.6% and female-specific ADR at 43.2%. These values were each significantly higher than the corresponding values in direct screening colonoscopy, where overall ADR was 37.5%, male-specific ADR was 44.6%, and female-specific ADR was 28.2%. FIT-positive colonoscopy also had a higher advanced adenoma detection rate at almost 30% compared to roughly 5% in direct screening colonoscopy. And there were 1.24 adenomas per FIT-positive colonoscopy compared to 0.73 adenomas per direct screening colonoscopy. Again, a significant difference. We also performed a subgroup analysis on roughly 2,500 subjects who had complete baseline clinical characteristics, so to exclude the effect of confounders. And the results again showed ADR, advanced adenoma detection rate, and adenoma per colonoscopy were significantly higher in FIT positive colonoscopy than direct screening colonoscopy. Our study builds on a number of strengths. Most importantly, we included patients and endoscopists from 8 sites across the Asia-Pacific, which increases the generalizability of the results to different geographic and ethnic groups. Our decision to include only one type of quantitative FIT with a uniform cutoff for positivity also overcomes differences in performance characteristics from using different types of FIT, even with the same cutoff. We were also careful in including only the first colonoscopy performed after a positive FIT, and to use only colonoscopies which were complete and of fair bowel preparation. Our results are also reassuring in that the significant differences observed using the entire Asia-Pacific cohort were also found at individual study sites. In conclusion, our study showed that ADR, advanced adenoma detection rate, and adenoma per colonoscopy in FIT positive colonoscopy are significantly higher than in direct screening colonoscopy, even after adjustment for multiple patient factors. Our findings contribute to the evidence in support of the higher ADR targets in FIT positive colonoscopy recently proposed by the US Multi-Society Task Force. Our findings also suggest that when calculating ADR, direct screening colonoscopy and FIT positive colonoscopies should not be combined together. We hope you have found our results impactful on your clinical practice. We encourage you to read the full manuscript for additional details and to share it with your colleagues. Thank you.